All right.
All right.
Welcome,
Well,
everyone. Go
yeah,
ahead,
thank
Steph.
you. Great. Yeah, so thanks for everyone for joining us today. This is the third talk in our Speakers and Social series. We're really excited to introduce Dr. Melissa Carter. Some of you are already familiar with her. She's a clinical geneticist at the Children's Hospital of Eastern Ontario in Ottawa, and she's also our medical advisor. So she's fantastic in supporting our families. She's done studies on 22q duplication, as well as helped us with the largest study on Emmanuel syndrome to date. That's how we got to know her, and we managed to snag her into supporting our group. She also helps with website content and guides and answering questions, and sometimes I just bug her for reasons. Anyways, thank you so much, Melissa, for joining us today to talk about some of the common questions that we as parents ask, especially when we're new to the world of genetics. And so some of the questions that we're going to be talking about today have come from our book, Raising the Goddess of Spring. So she's also contributed to that in a couple of chapters. And so we took some of those questions, as well as some of the questions that some parents have provided privately. So without further ado, we'll take it away, Melissa.
Thanks, Steph. So I guess what we're going to do is you're going to ask me questions as we go through this slideshow, and I can give an answer. And then if people have questions related to that question, maybe they could put it in the chat potentially, or ask, oops, someone's coming in afterwards. And we'll just see how many we can get through in the time. First one here.
So yeah, so one of the burning questions I know that a lot of people have is, you know, as a doctor working in the field of genetics and also in developmental disability, what brought you here?
Well, I really liked biology in high school, and particularly learning about genetics was fun back then, and I wanted to learn more. So I ended up studying genetics in undergrad, but I wasn't sure what I wanted to do for my career when I graduated from my bachelor's. So I did a master's degree in genetics. And it's because I knew I wanted to do something in genetics. And in a master's degree, I was working in a lab doing research on mouse DNA, and I didn't find that very exciting. But as part of my degree, I took a course in human genetics, and that was fascinating for me. And one of the people who was lecturing in that course was a clinical geneticist. And so that's when I learned what that was and how you would go about doing that. You have to go to medical school, and then you have to do residency, and then you become a doctor who specializes in diagnosing genetic conditions. So I went down that rather long path. It's medical school, and then it's 5 years of residency. I did an additional 2 years of fellowship for developmental disabilities after that. And I've been practicing for about 10 years now. And it's a really exciting field because there have been so many advances just since I graduated. And there are tests we do routinely on a daily basis now that had not even been invented yet when I was training. So that's really exciting, and it's continuing to evolve, and it's always changing. So that's part of the reason why I am doing this for my career.
Wow, that's an incredible academic commitment, and exciting to hear that there's all these different changes. I've seen that even since Maya was born in 1995 for sure, but yeah. Yeah, so the next question, I'm waiting to see a geneticist for the first time. What should I expect and what should I ask?
Yeah, there are really two main reasons people get referred to me. One is because the doctor who's referring suspects there might be a genetic disorder underlying whatever problem the patient has. And my job is to determine what genetic testing would be best to try to figure that out. And then the other reason would be you've already had a genetic test that was done maybe by your pediatrician on your child, for example, and the pediatrician wants your help in trying to interpret the result and to tell you, what the result means and how it relates to your child and that kind of thing. So the majority of patients that I see are children with developmental delays, and sometimes they've had genetic testing done, sometimes they haven't when they get to me. And probably the most common test that I deal with actually is our chromosome tests. And these are a standard part of the investigations when a child has developmental delay. So pediatricians can order them, family doctors, although they don't all feel comfortable. And if the chromosome test is normal, then they come to me and I can talk about additional tests. And if it's abnormal, then I will spend time talking to the family about what it means. And I'll talk about the different types of tests in the next question. But what in terms of what you should expect, there's a typical encounter would be you sit down together in a room, or these days maybe over Zoom, depending on how it's done. I've been doing a lot of Zoom consults. And I will ask you a bunch of questions about your child, just so I get to know who the child is, what the child's issues are. And then also we take a family history, so very detailed family tree. And so it's helpful if you sort of have asked around your family members, if possible, does anybody have any medical conditions? And because not every family talks about that out in the open. So if it's possible to gather some information ahead of time, that's really helpful. Although if you can't get it, like say you're adopted or something, that's still fine. But getting more information is always good. And in terms of the second part, there's usually a physical examination. So that part does usually have to be in person. And a geneticist does a very sort of external examination, looking at the face, the facial features, hands and feet. Maybe we'll take some measurements, that kind of thing. And then there's a part where either I'm explaining the test results to the patient, or I'm recommending a certain testing strategy and organizing that for the patient. And so there may be some blood work involved after, depending on what we decide. And what should you ask? I mean, you should ask anything that you want to ask. Don't be afraid. There's no stupid questions. And there's some of the questions that parents often ask, I'll address in another slide. But I mean, I can't say anything particular you should ask other than what is it that you really want to know. Just don't be afraid to ask.
Awesome. Does anyone have anything to add before we move forward? No? Okay. Okay, so can you tell me about the different types of genetic tests and when they are used, and how long do test results usually take?
Yeah, so when I started my training, there were very limited options for genetic testing. You could do a karyotype, which I'm sure some people have had or their children have had.
Pause it, just stops it, doesn't it? There's not a way to
Sorry,
pause it.
can I, yeah, thank you. Sorry, Melissa.
That's okay. Yeah, so chromosome test used to be done by doing a karyotype. We can still do that, but we now do microarrays to get more finer details on the chromosomes. And then FISH is a test where we target a specific.
Oops, hang on. Melissa got muted by accident.
Yep, I got muted. Whoops. Okay. Okay, what was I saying? I'm not sure when I got muted, but anyway, so the chromosome tests that we do. So I already mentioned those. They're the most common thing that we do. And of the people who are watching, I'm sure any of their children may have had any one of the following, probably a microarray if your child was diagnosed in the past 10 years. If long time ago, it might have been a karyotype, which we can still do, but it has a lot less detail in it. And we'll see some pictures of that later. Or potentially a FISH test, which is sort of a very targeted test to look at a specific chromosome region. So before we had microarray, we would do FISH to see if someone has the 22q11 deletion, for example. And so chromosome tests, pretty much those are the ones. The microarray is the one that we use the most now and gives us the most detail about missing our extra pieces of chromosomes. And so the microarray came out roughly about halfway through my training in around 2006 or 7. We've been doing them ever since, kind of our first line tests for developmental delays and congenital birth differences. And there are a lot of genes that you can test just by looking at someone's DNA in their blood if you suspect a certain condition. So for example, you may have heard of Fragile X. syndrome, which is a condition caused by a single gene on the X chromosome. And that's a fairly common test that maybe some of your kids have had as well, just to rule it out. But, you know, we don't do so many single gene tests these days. We often will do multiple genes at once. And there's different ways of doing that. So you can look at a panel. So we call them multi-gene panels, where we can look at up to literally thousands of genes at one time, just to see, you know, we have all the genes that are associated with developmental disability, and we can do that all in one blood sample now. And then the final one that maybe some of you have experienced as well is exome sequencing. And that's basically sequencing all the genes and looking at them each individually to see if there are any mutations in any of those genes. So the multi-gene panels and exome sequencing were not available when I was a resident. They came in the past, I'd say 5 to 6 years,
Wow.
because of a technology called next generation sequencing. So they're really, really powerful tests. When are they used? Oh yes, so when are they used? So the chromosome test, I think, as I mentioned, is very standard, done in children with developmental delay and birth differences, and then a variety of other reasons. The multi-gene panels and exome sequencing are used usually if you've done a chromosome test and it's come back normal and you still suspect a genetic condition, you go to these other tests. And they're very expensive tests. I mean, the healthcare system will pay for them in Canada anyway. It depends on where you are, but they're regulated in the sense that not everybody can do one. Not everyone can order it. Only I can order it. Your family doctor can't order it, for example, or your pediatrician. And because they're very complex to interpret. So, but they're very powerful. And how long do they take? It depends on the test and it depends on the lab. So the chromosome tests in my center take about 4 months to get the results back, but I've certainly heard of other places where they're a lot quicker, a month, 2 months. So it depends on how busy your lab is and how many samples they have to process. Single gene tests and multi-gene panels can take as short as a few weeks or as long as a few months. And exome sequencing typically takes that long. And it's not because the technology itself takes that long, it's because labs are processing probably hundreds to thousands of samples. And so they all go in a queue and then they get done one at a time. Occasionally, let's say you're pregnant and you have a pregnant mom and you need an answer right away. Sometimes that will get them bumped to the front of the line and you'll get it a lot quicker. I think that's all I was going to say about that. Any questions about that?
So our next question is, have you ever had an experience where you suspect a genetic disorder and then the tests don't show anything?
Yes, it happens all the time. It's very frequent. So I'd say like the typical child I would see in my clinic when I'm doing genetic testing on them, probably about 10 to 20% of them will have a chromosome anomaly when we do the test. And then another 20% or so might get a diagnosis based on a multi-gene panel or an exome test. But so that leaves at least about 50% undiagnosed by genetic testing. And, we're not really sure why are we missing certain things. Are there genes we just haven't really, I don't want to say discovered because we know where all the genes are, but maybe we don't know if the gene causes a disease or a disorder yet. So we need to wait for more research to be done to discover it in a person. Sometimes it's just not genetic, but we don't have really good tests at figuring out what it is if it's not genetic. So one example would be fetal alcohol syndrome. So if a mother drinks a lot of alcohol during pregnancy, it can cause developmental delays in the child and other things. So that's a non-genetic condition, which would not show up on a genetic test. And then there's also probably a lot of kids, usually kids with sort of autism and other sort of general developmental delays where it's probably not just a single gene or single chromosome problem. It's probably multiple genes interacting together. And we're not very good at picking those up yet. We don't fully understand how multifactorial inheritance works yet. So that's an area of future research.
Okay, so our next question, what kinds of chromosome differences are there?
Excuse me. Okay, so Stephanie put this picture up on the slide. It's very nice. I'm gonna just ignore it for a second, and then I'll go on to another slide in a second. So there are basically two categories of chromosome differences. So one is numerical, and I'll go to the next slide. So a common example of a numerical chromosome difference is Down syndrome or trisomy 21. And this is what a karyotype looks like. I mean, it's a cartoon, obviously, but this is the general idea. You know, we all have 23 pairs of chromosomes. We have chromosomes 1 to 22, which are the chromosomes we all have in common, and then the X and the Y. So this would be a male because there's a Y, and females would have 2 X's instead. And with Down syndrome, well, it's called trisomy 21 because there are 3 copies of chromosome 21. So that's a numerical chromosome difference. Some other numerical chromosome differences would be Turner syndrome, which is where instead of 2 X's or an X and a Y, there's only 1 X. So that causes a condition in they're females, but they have difficulties with puberty and they're infertile and things like that. And then there are some other sort of trisomies and different chromosomes that we can see, but a lot of them are not, they're more likely to miscarry than to actually result in a live birth because it's a very large chromosome imbalance. And since this is chromosome 22 central, I'll just mention that a trisomy of chromosome 22 or a monosomy where there's only 1 of 22 in general is not going to result in a live born child unless in the case of the trisomy, the child could be mosaic, which means some of the cells have the extra chromosome and some of the cells don't, but it's extremely rare to see trisomy 22. Okay. Oh, this is, I guess maybe I'll go back to this for just 1 second. The other 22 related condition that's sort of in this category is cat eye syndrome. So, I mean, that's the old name for it, but basically that's a partial trisomy or partial tetrasomy of part of chromosome 22. I don't have a picture of it, but it basically means there's like a whole extra chromosome that is not the entire chromosome 22, but it might have a piece of 22 extra or 2 pieces of chromosome 22 extra. And that causes cat eye syndrome. And then the other category is structural chromosome differences. And there's lots and lots of different ones, but I'll just tell you about some of the commoner ones. So a deletion is so this is a chromosome, there are genes lined up all along the chromosome. And then if there's 2 breaks in the chromosome, this piece in the middle of the breaks gets lost. And so you have a much shorter chromosome. So that's called a deletion. It means a number of genes are missing. And the most common example of this with respect to chromosome 22 is the 22q11 deletion syndrome, which used to be called DeGeorge syndrome or velocardiofacial syndrome. Most of the time, I would say deletions are not inherited from a parent, although they can be, depending on the size of them and what genes are affected. So often they're de novo, which means they happen in the egg or the sperm, and they're not inherited. So I'll talk a little bit more about that in a second. Besides 22q deletion syndrome, there's also another chromosome 22 condition called Phelan-McDermid syndrome, and that is also a deletion of chromosome 22, but it's a different part of chromosome 22. So it's the bottom little bit of 22 that is deleted in Phelan-McDermid, and that will always include the SHANK3 gene, but also a number of other genes. So very different conditions, even though they affect the same chromosome, they affect a completely different set of genes. So they look very different from each other, or they usually do. So duplications are just kind of the opposite of deletions. Instead of having missing parts, you have extra parts. So if this little pink and green region here is duplicated, that might look like this, where the chromosome gets longer and has extra bits. So all the genes that are present in this duplicated area, whereas they used to be present in 2 copies, they're now present in 3 copies. So it's sort of a partial trisomy. And duplications are really common. There is a very common duplication that is the same region as the deletion in chromosome 22q11.2 deletion syndrome, but instead of missing, it's extra. And that's very, very common. That's one of the conditions that I've studied. And it has a wide range of effects from completely normal, unaffected to developmental delays and such. And that's often inherited from a parent. So duplications in general, depending on the size of them, are less sort of impactful than deletions. So having extra genes in general is not quite as disruptive to development as missing genes, depending on the genes. Duplications of other parts of chromosome 22 are also seen, but are a lot more rare. And then, of course, there is translocations, which are a bit tricky to understand sometimes, but this diagram will show you that if you have two different chromosomes, so this might be an 11 and a 22, for example, and they actually switch pieces. So part of the 11 is on the 22 and part of the 22 is on the 11. And that's okay if nothing is missing, nothing's deleted, nothing's duplicated. And you can be walking around with this and be perfectly fine until you go to have babies. And then you could experience miscarriages, or you could have a baby with miscarriages or infertility, or you could have a baby who has an unbalanced form of your translocation. So that's what Emmanuel syndrome is. So in an unbalanced translocation, you'll have, let's say you have the father is not a translocation carrier and the mother is a translocation carrier. She'll only give one of these two chromosomes to her offspring, so in her eggs. And therefore, when they pair together with the father's chromosomes, you're missing a piece of one chromosome and you have an extra piece in another chromosome. So that's unbalanced. So that's a deletion and a duplication, and that usually results in some kind of effects, most commonly developmental disabilities and birth defects. And rings are actually not that common, but I just thought I'd show them as another type of chromosome difference. This is when a bit from the top and a bit from the bottom of the chromosome break off, and that makes the ends sticky. So they stick together and form a ring that fuses like this. And this is uncommon because it's very unstable. And so when cells divide, this ring chromosome often gets lost. And then if you're missing a big chunk of a chromosome, often that means the cell won't survive. But occasionally it happens when an embryo is forming in one or two cells and it gets propagated, and then you have whatever condition is associated with it. But there's a wide range of effects because it depends on the chromosome, depends on how much you lost and how many of your cells actually have the ring in it. So that's my overview in a nutshell of chromosome differences. Does anyone want me to comment?
There's
There is a
actually
question in the chat too.
Yeah, sorry, there was one question from Lisa in the chat. Do all genetic tests, fish, etc., identify these differences, deletion, translocation, and duplication?
Yeah, that's a good question. So no, you can. So the microarray, that test that we do most often now, is excellent at picking up any imbalances, deletions, duplications, unbalanced translocations, rings that have pieces missing. So they can tell you, is there an imbalance or not? Now, in order to see if it's a ring or if it's a translocation, you need to know the structure of the chromosomes. That's when you have to do a karyotype or a fish or both to show the actual structure, because the karyotype is a picture looked at under the microscope, whereas the microarray is done differently. It's just more of a quantification of different chromosome regions. Let me just see here. Fish identify. Okay, so yeah, if someone were to come in and say, you know, they had multiple miscarriages and they wanted to know why, one of the tests the doctor might order is a karyotype, because if you ordered a microarray on that person, it would be normal because they're not missing anything. They don't have anything extra. But you look on the karyotype and you can see that the two chromosomes have switched places. Whereas in a child with 22q deletion syndrome, for example, you do a karyotype and often it'll be normal because the karyotype doesn't zoom in enough on the chromosomes to see where the piece is missing. You can do it by fish, which is done partly on the chromosomes or on the karyotype, if you're looking specifically for it. But if you don't know what you're looking for, you're just looking for missing and extra pieces, then you really can only really do it with a microarray. And I hope that answers the question.
Thanks, Melissa. Oh, yes. So the next question is, how and why do chromosome differences happen?
So the how we mostly have figured out. The why we still don't know. We know that in a lab, if you take bacterial cells, which also have chromosomes, or you take cells from a mammal that are growing in culture, and you expose those cells to different things like radiation or certain chemicals, that can induce chromosome differences. But those aren't factors usually in a human's day-to-day life. So we have not really figured out why they happen, other than it is a part of sort of a random chance process that can happen to anyone at any time. And the body is somewhat good at finding those errors and either fixing them or doing away with them, but it misses things. We miss things. And so it's sort of it's a random chance kind of thing. The how is complex, and you really have to have sort of a deep understanding of molecular biology. That's way beyond the scope today, but in simple terms, chromosomes go through a process when you're making your eggs or your sperm, your gametes, inside your ovaries or your testes, depending on if you're a woman or a man. And those chromosomes have to completely reproduce themselves, and then the cells divide. I have a picture of these. I do, I think, actually. They have to reproduce themselves and then divide in order to make eggs and sperm that only have one copy of every chromosome instead of the two that are in most of our body cells. So non-disjunction is something that can happen when, for example, in Down syndrome with trisomies. So what should happen is you have the yellow chromosome, say that's 21, and it duplicates itself and then gives one copy to each daughter cell, and then the other one does the same. But then when they actually don't separate, like here, let's say the blue is 21, then the egg, say that's the egg, for example, the egg will then meet with a sperm, which will have a normal chromosome 21, and then you end up with 3. So it just means they don't pull apart properly, and it's just an error. The deletions and duplications and rings and things like that in general happen in the process of a very normal thing that happens, which is when chromosomes duplicate themselves, they pair up with their partners. So say this is chromosome 22, it duplicates itself, and then those partners pair and they swap pieces. And that's supposed to be very even. So we'll swap this arm here, and that's part of the normal way we create diversity in our genetic code. And it should be fine, except sometimes it goes a little wrong. So sometimes they don't do an exactly even swapping. And that's how you end up with deletions and duplications, and then some more complex rearrangements. So these are normal processes that can get, that errors can be made in. And most of the time, when an error happens, that cell does not go on to create an embryo. It does not. It's not a successful egg. It's not a successful sperm. There are others that do the job, but occasionally you do get an error, of course, which will then make an embryo. Sometimes that embryo won't implant, so you don't get pregnant, or sometimes you get pregnant, but the miscarriage occurs very, very early. And then other times, so I'm talking probably 1% of the time, you go on to have a live birth. And that's sort of the story there. That makes sense.
There's one question in the chat. Is that okay? The question is, are there any common health issues in balanced 1122 translocation carriers that have been studied or documented?
Yeah, we did a study way back when I was a resident, where we asked chromosome 1122 translocation carriers about their history of cancer, because there had been some case reports of breast cancer, I believe. Was it breast cancer stuff? I can't even remember.
Yeah, there's 2 or 3 older small studies that talk about breast cancer.
Yeah, and we were trying to figure out, is that true? Is there an actual increased risk or not? And I think we had a small number of patients, and we didn't find that it was overly increased. I think I'm not really up on the literature since then. I think there have been other studies that maybe make a suggestion, but I'm not sure if it's a resolved question or not. Generally speaking, balanced translocation carriers are not at risk of any health problems except for infertility and miscarriage.
Yeah, and breast cancer, as far as I understand, is just so common in the human population that, yeah. Okay.
Most common cancer in women, I think, yeah.
Yeah, so, okay. So can chromosome disorders be prevented?
In a word, no. We can't prevent them from happening. It's normal for these processes with cells dividing and replicating chromosomes and switching pieces. That's all normal, and that needs to happen. And we can't really mess with that. And so that's when it actually happens. Once it happens, we can't fix it at this point. So we can't, give back a piece that's missing or take away a part that's extra. That's not something that we can do. So at this point, we can't really prevent that it happens in the first place, and we can't fix it if it happens. The only thing we can do is to potentially prevent the birth of someone with a chromosome disorder, which is not always what people want to do, of course, but there are various ways that people have done that. So one is through prenatal screening, which maybe a lot of people know about if they've had a baby in the past 10 years. A lot of places will have maternal blood tests and ultrasounds to look for Down syndrome, to look for certain trisomies like 13 and 18. And when you pick up those either chemical markers or ultrasound findings, then you can get more information by doing prenatal diagnosis, which usually means an amniocentesis, so taking some fluid with a needle from around the fetus, and then looking at the chromosomes in the same way that you would look at them in a child or an adult, by looking at the karyotype and looking at the McMaster. And so these are two ways that you can diagnose them very early. And some people, depending on the difference, may decide they don't want to continue the pregnancy, and some people do. And then the last way to prevent it is if you know that you're at risk of having a child with a chromosome disorder, and that would typically be someone who's a balanced translocation carrier, then you can, you can not have children, you can adopt children, you can have an egg donor or sperm donor, or you could do pre-implantation diagnosis, which is using IVF in vitro. You can use your own naturally conceived embryos, but they would be conceived in a lab. They could be tested in the lab, and those that have the unbalanced chromosome would not be put back in to the mother to achieve a pregnancy. You would just put the ones with the balanced chromosomes back in. That's a very expensive procedure, and it doesn't always work, but it is a possibility for some people.
Thank you. Any other questions to follow up that? No? Okay. What are the most common concerns that you hear from parents who see you?
Parents want to know what the future will look like for their child. That's the most common thing. And it's also the hardest to answer because I don't think anyone really knows. You can, even with something very common like Down syndrome, you can say, this is what the average child with Down syndrome looks like. This is what the best case scenario is. This is maybe the worst case scenario, but you can't really predict with any degree of certainty. And that's especially challenging when the condition is rare or understudied. So a lot of the chromosome 22 disorders, some of them are very common and some of them are very rare. So you can only really tell people the information that you have. And I know that's frustrating for parents because they really do want answers. I find it's when the child is very young when they're diagnosed, it's a lot harder. When the child is older or an adult, I find it's a different kind of conversation. Parents aren't asking me what the future will look like. They're asking me, how did this happen? Or they're just really happy that they have an answer. because they've been looking for answers for a long time in many cases. And then another thing people want to know is recurrence risk. So the chance that they could have another child with the same condition. And for most chromosome disorders, the risk is actually very low because there's spontaneous events, but there's exceptions. Obviously, if a mother or a father has the same thing, they can pass it on to their child with a high degree of likelihood, 50% chance. And if you're a translocation carrier, you're going to have a recurrence risk that sort of is a range. I can't put a specific number on it of having a child with an imbalance. So those are sort of the exceptions. So it depends on whether it's inherited or not, what the recurrence risk is going to be. And I think those are the two most common things that parents will ask me.
Thanks, Melissa. There's one question in the chat. If you have a healthy embryo via IVF and it's tested, et cetera, is there still a chance that the embryo could be affected genetically?
There's always a chance. There's lots of spontaneous mutations that can happen after conception. Most mutations happen in the egg or the sperm, but then sometimes, the egg and the sperm have no genetic differences, we'll say, and then an embryo is formed. And then as the embryo is growing and dividing, a genetic issue could arise, whether it's a chromosome difference or a single gene mutation. So there's still a chance, there's always a chance, but then it would be sort of the same chance as anyone else in the general population, as opposed to whatever it was before you started the journey.
Okay, so this was something that I think a couple of people asked. Many of our children experience seizures. Can you explain a little bit about seizures?
Yeah, sure. So I'm not a neurologist, so I couldn't really answer any very specific questions about how to treat them, but I can tell you very generally about them. They're very common. They're common in people in general. So about 5% of all people could have a seizure, at least one seizure in their lifetime. But in children, among children and adults with chromosome differences, they are much more common. And I don't have a number for you. It kind of depends on the condition, but they can be pretty common. And we don't really know exactly why they happen, but it sort of comes down to probably a similar reason, that there are developmental differences in that when you have a chromosome imbalance, the brain just develops differently. And a seizure, what a seizure is in a cellular level, is a burst of electrical activity between brain cells, which are called neurons, that sort of burst uncontrolled. Your brain is always passing electrical currents back and forth between cells. That's normal, but it's very controlled. And so a seizure is when it becomes uncontrolled. And what that will result in is differences that you can see in the body. Muscle tone differences like stiffness, twitching, movements. You could lose consciousness. You could have some funny behaviors or funny sensations or smells. So it depends on where in the brain that's all happening, what it's going to look like. And if you have one seizure, you've had a seizure, but if you have more than one seizure and you continue to have a propensity for seizures, that's called having epilepsy. Just going to get to that in a second. So there are many types of seizures, like I said, and they can all look very different. They can be really, really short and almost unnoticeable, like an absence seizure, or they can last for minutes and they can be very dramatic and scary looking. The most common is like the generalized tonic-clonic seizure. But you can also have focal seizures, which means it starts in one part of the brain and it affects maybe just your arm or just your leg. And sometimes it starts focally in the brain and then it spreads across the whole brain and turns into a generalized seizure. So that can be scary to watch or to have it happen to you. But the good news is many times it can be treated or managed with medication. And hopefully you don't have any more seizures. Sometimes you will have seizures, or it can take a while to get the medications right, but generally the prognosis is pretty good. I guess a common thing parents want to know is like, how will I know if my kid's is having a seizure? Most of the time, if it's a minor seizure, you may or may not notice, but that's okay. If it's a major seizure, you're going to know. Basically, you will know what's happening. But the important thing is not to panic. It does not cause brain damage. You just time the seizure, you turn them on their side, make sure they're safe, make sure they're comfortable. Just wait it out. It shouldn't last for more than a few minutes, even though it'll feel like a century. Just make sure there's something soft under the head. Never put anything in the mouth. Never put your fingers or a stick or anything in their mouth, because they cannot control their jaw if they're having a major seizure. And if the seizure is going on and on forever, call 911. In fact, if it's the first time your kid's had a seizure, you should call 911. But once you're comfortable with it, seizures can be managed at home without having to go to the hospital when you feel confident about it and they don't go too long.
Thanks. That's pretty reassuring. There's a couple questions in the chat. Are you okay with that?
Mm-hmm.
Okay. Just go back up here. Someone asks, have there been any studies of individuals with Emmanuel syndrome and autism?
Not that I'm aware of. So autism is a behavioral diagnosis. So I won't go into the details about what autism is, but there are specific criteria that someone needs to meet in order to be diagnosed with autism. But there are also autistic behaviors, which can look like autism, but maybe isn't accompanied with all the other things that go with autism. So for example, hand flapping, you often see in kids with autism as a repetitive behavior, but you can see that in other kids too. So as far as studying autism in ES, I'm not aware that anyone's looked specifically at it. Certainly there are lots of case reports out there where maybe a child has been diagnosed with autism, but it's not the same as sort of the autism that we know is very common. It just might look like autism, if that makes sense.
Yeah, and I actually recently just sort of went through and compiled a list of dozens and dozens of reports on Emmanuel syndrome, and maybe there's a passing comment about autistic features, but nothing specific to autism itself.
Yeah, I mean, I think there's a bit of you usually go with the diagnosis that's the most fitting, right? So if you've been diagnosed with Emmanuel syndrome or 22q deletion or whatever, that's the diagnosis that usually supersedes everything else. You can get other diagnoses on top, but it might not be mentioned in a case report, for example.
Thanks. Okay, and the next question that's here is, do you ever have parents approach you who are concerned about their older child and the risk of schizophrenia? Are there genes yet identified that correlate with this condition?
It's not a common question. When we diagnose 22q11 deletion syndrome, it is something we go through because there does seem to be an increased likelihood of schizophrenia with that particular condition. That is not true of all chromosome disorders. So we do talk about that when we have a new diagnosis of 22q11 deletion. And then sometimes if the child's been diagnosed young with that, and then, they get older, maybe the parents might have read about it or have been thinking about it, wondering like, what does it look like? And what should I do if, I'm concerned about it? So yeah, they will ask about it. I'm not up to date on the literature about the genes associated with schizophrenia. So I couldn't speak to that today, but we know schizophrenia is highly genetic, and we know that there are a lot of genetic factors that contribute to it. If you have schizophrenia, you're likely to have a family history with schizophrenia and that kind of thing. So, so I don't know if that answers the question, but I'm not fully up on the know on schizophrenia.
For the person who asked that question, if you want to join us on November 10th, I believe it is, at 7 o'clock, we have Donna McDonald-McGinn from the Children's Hospital in Philadelphia, who will be speaking about the 22q11 11.2 deletion and duplication, and she'll be asking or answering questions as well. So you might want to bring that to that session.
Yeah, she'd be a great one to ask.
Thanks. So one of the questions here is, sorry if this was asked already, Did you have life experience with disabled children or adults that led you to your career? And how has meeting and getting to know people with disabilities affected your life?
I don't have any personal connections. Like I don't have any family members or close friends who have disabled children. But when I was training for like in medical school, and you do rotations in different areas, in pediatrics in particular, you do work with a lot of children with disabilities, and that I was really drawn to that particular field because, well, for a lot of reasons, but I mean, I really enjoyed meeting the families, and every child was very unique. And it was a bit of the puzzle of how this happened was very intriguing to me. And so that's exactly what I do. I try to sort out the puzzle. I try to solve the mystery of what happened. So I was just drawn to those children and those rotations when I was learning about medicine. I really did not want to work with old people. They were just not my cup of tea. I was just really drawn to the children. And then meeting and getting to know people with disabilities affected my life. Yeah, that's a really great question. I have not given a lot of thought to that, but I think I should, because I know that it's definitely made me more aware of the struggles and the inequities, especially in society, that face people with disabilities. And that I don't know where everyone's from here, but in Canada, although we have a universal healthcare system, parents are often saying, you know, when my child turns 18, it's like they fall off a cliff because there's no services. And, you know, suddenly all the pediatric providers don't want to see you anymore. And you get passed off to these adult doctors who aren't comfortable. And it's really a huge issue. And I bet it's not better in other countries, if I had to guess. So no, that's a really great question, but I just really love working with these families. They're some of the strongest children and parents that you meet.
Thanks, Melissa. Yeah, and Joe said that that's similar in the UK, and I've sort of felt that as a parent of an adult as well. So our next question is, some of our children have muscle tone issues such as hypotonia or hypertonia. How can this affect our children long term?
Yeah, I think this is the last question that we had planned. Okay, so hypotonia and hypertonia are sort of two ends of a spectrum of muscle tone issues. So it may or may not surprise you to know that problems with muscle tone are actually due to the brain, not the muscles themselves. The muscles are normal, or at least they start out normal. And then it's the signals that the brain gives to the muscles via the spinal cord that is the problem. And the normal state of your muscle tone is that you need to be somewhere between totally relaxed and totally contracted. And then you have to have the ability to change the state of your muscle tone quickly, depending on what you're doing. So, you know, when I go to stand up, I have to increase the muscle tone in my legs, and I do it without thinking about it. My body just knows how to do it. When I go to sleep at night, I lose muscle tone so I can rest and rejuvenate, and I don't have to think about it. My body just does it. So if you have a disability that involves a tone difference or abnormality, then a lot of those things are a struggle. So low muscle tone or hypotonia is super common in kids with chromosome disorders. If the brain is affected, and most kids with chromosome disorders do have an effect on their brain. And so if the brain isn't sending strong signals to the muscles to stay contracted, then they might feel floppy. Their muscles don't feel normal. So this picture, so this is let's say these are two babies the same age. I don't know if they really are. So this is the normal state. So you hold a baby up that way and they'll lift up their legs and their head a little bit. But if you have hypotonia, you're floppy. You can't really lift. And it's not really that you're weak. It's that you just don't have that muscle control. So that's a baby with hypotonia. And then depending on how severe the hypotonia is, that can affect the child's development in many ways. So Often there are delays in meeting motor milestones like sitting and walking. You can have difficulty with grip and holding a pencil or feeding yourself. And it's related to, not just your skeletal muscles, but also the muscles that make up your gastrointestinal system and the muscles that move your eyes and things like that. So you could have a lot of reflux, constipation, drooling, strabismus, all as a result of hypertonia. But hypotonia tends to get better over time to some extent as the brain develops and matures and the child practices motor pattern and gets stronger through physical activity. So if you're born hypotonic, you won't necessarily stay hypotonic. Generally, it'll improve a little bit and to a certain point, and then maybe not so much anymore, but your muscle strength takes over and then you're able to compensate more. Hypertonia, on the other hand, just go back to this one. Hypertonia is the opposite. So the muscles, instead of being floppy, they're in a constant state of contraction. So that makes it really hard to move in a normal way. And unlike hypotonia, hypertonia tends to either stay the same or get worse over time. And if it's present at birth, that's usually a signifier to the doctor that there's a fairly significant abnormality in how the motor centers of the brain have developed or potentially have been damaged. And sometimes hypertonia is not present at birth. It's more, usually we'll see a baby who's hypotonic, whose tone will improve and then will go in the opposite direction. So get hypertonic over time. And the effects of hypertonia are similar to those of hypotonia, but for different reasons. So motor milestones are delayed, especially if the legs are affected, which they often are. Sometimes motor milestones aren't achieved, like walking independently, depending on the severity of the hypertonia. Tight muscles and not moving your limbs because your muscles are tight can result in contractures, which are deformities of the limb that can make movement even more difficult. So you either just can't open, let's say you can't extend, or you can't bend a joint because of contracture. So there's unfortunately no good cure for hypertonia. You don't have a lot of treatment options. You can take medications that can decrease your muscle tone, but they have really pretty bad side effects like sleepiness, which is not great for learning and developing. So the mainstay of treating hypertonia would be physiotherapy to control the motor, to improve your motor control and prevent contractures. We have a lot of kids with hypertonia who have a lot of physiotherapy. And it may or may not be necessary for hypotonia, depending on how severe it is.
It's one of the best explanations I've ever heard of that. Actually, made a lot of sense to me. There's one question related to that. Do you see the progression from hypo to hypertonia? I think that's what she means, in people with Emmanuel syndrome.
Yeah, that's a good question. I haven't seen a person with Emmanuel syndrome in many years. But if I had to guess, I would say probably they start out pretty low tone. And then, yeah, that's what she meant. They start out pretty low tone, and either their tone will improve and stay, well, it might stay low, it might improve, and it could progress to hypertonia. I don't think that's common, but I think it can progress. And I think kids who are less mobile are definitely the ones that are going to be at risk from this stiffening over time. So, which is just part of the reason why it's so important to try to stay as mobile as possible, even if it means, using a walker or a stander or, anything like that. It's very important to, move, keep moving to prevent that kind of increased disability.
Thank you so much. I think that was all the questions that we had submitted, and we've had a few submitted just here in the chat. Is there anyone else who has any final questions for Dr. Carter? Here's one. How far is genetic testing getting in being able to predict medical conditions that will arise with a particular microdeletion or a translocation?
Okay, I'm just going to bring up my chat box so I can see it. Okay. Medical conditions that will arise with a particular microdeletion or translocation. I would say it hasn't gotten anywhere, frankly. You know, if you have a microdeletion or a translocation, we know the way we know what we know about how that affects people is by studying people with that. It's not by looking at the individual genes so much, although there are scientists that might be looking at that. So I can't, for example, have two children in front of me with 22q deletion, for example, and I can look at how big the deletion is, but generally there's not a good correlation between the size and that particular condition. But I can't go in and do other genetic testing that's going to tell me, will they have schizophrenia, for example, at least not clinically. On a research basis, maybe there are people studying this, but at this point, that's not a tool that I have in my arsenal in the clinic.
Thank you very much. I think we probably could stop the recording now, Maureen.
Sure.
Let's do that.